So to start, I always put this quote up because, I think people come into the labor process. We're all first-time moms, right? Yeah, I'm not misremembering that. So, I think people come into labor with a lot of fear and trepidation because, your entire life you've been told like this is going to be the worst, most terrible experience ever, right? Can somebody name like when you hear labor, what comes to mind? Screaming, yeah, pain. How about you guys? The same, yeah. I mean, that's the impression, right? And but instead, I always say, no, labor is not that. Labor is a marathon. It's hard work. It's like climbing a mountain, but at the top of that mountain, it is this, if you've ever climbed one, it's this awesome, amazing sense of accomplishment. And certainly, this is the most beautiful sight you get. And so, part of today's purpose is to begin sort of breaking down sort of those preconditioned ideas about what your labor experience is going to be. Because if we can let go of that, the whole premise of conscious birth preparation is if we can really break down the fear and anxiety surrounding childbirth, then we can actually break down a lot of the discomfort as well. So that's what we're working towards. So today, our first class, the whole point is going to be to decrease fear and anxiety. We're going to really understand the process of labor because you don't fear what you understand. And we're going to help you become comfortable with labor terminology because, when you come into, especially if you're coming into the hospital environment, sometimes they can feel like people are speaking a different language about you. So we're going to give you the kind of the keys to understand that language, what sort of things you might hear among the medical personnel as they describe what's going on in your labor, so that it all feels very normal to you. And all of this is really to form the basis for shared decision making. So you know what to expect, you know what options you have, so that, if challenges come up in your labor, you can really make good informed choices about what you want to do. So we'll just jump right in terms of, beginning to explore how labor goes and what it looks like. So what the first question that I'm often asked is what initiates labor, especially for people who might be running a little bit late or afraid of going a little bit early. And interestingly, the whole what starts labor is a poorly understood mechanism. We think that there's probably a baby hormonal component. So the baby sends some sort of signal to mom to say, hey, I'm mature, I'm ready to be born. We think that there's a mom hormonal component. So, well, we don't think, we know there's definitely shifts and changes in mom's sort of hormonal milieu that helps prepare the body for labor and helps the mother's body be ready to both make the hormones that we need to make to help labor happen and also help her body be receptive to the labor process. And then there's a series of physical changes that happens in the mother's body that again helps her body be receptive to the labor process. So, and if we don't have kind of all of these things working together, interestingly, we see dysfunction in when labor starts. So, there's been studies, for example, in babies that maybe don't have a development of a certain type of their brain, that those moms won't go into labor. So kind of strange. Or if we give mom different hormones that are sort of pro-pregnancy, then we can delay premature labor. So all of these things definitely seem to be working together. So as far as the baby signal, we think that it's either just a mystery hormone that we haven't discovered, or possibly surfactant, which is a hormone that's released actually from the baby's lungs when the lungs become mature. In the mom's hormones, we see progesterone decrease. Progesterone is progestation, so as that decreases, then we see oxytocin and estrogen increase. And it's hypothesized that that decrease in progesterone is due to the placenta sort of reaching the end of its viability and sort of becoming old. So when that happens, then that hormone comes down and these other hormones can start to dominate. And oxytocin is the hormone that promotes uterine contractions. So that's a super important hormone in the labor process. And that helps the release of these different hormones. They also start a process called cervical ripening, which we're going to talk about, which is the cervix kind of remodeling to be ready to receive contractions. So oxytocin, it's a neuropeptide that's produced in the hypothalamus and it's secreted into the mom's bloodstream. And we make this hormone at different times. So it's kind of known as the love hormone. So this hormone is released during breastfeeding, it's released during bonding, it's released in sort of that moment where, you look across the room, lock eyes with a stranger, and all those feelings start. This is the hormone responsible for it. It's released during lovemaking, kissing, and interestingly, you never have higher amounts of oxytocin in your system than when you are being born and when you are giving birth. So super interesting in terms of just how that may interact with sort of the bonding of mom and baby together. So very cool. So in terms of what happens physically in mom's body, the changes that we see as we progress into labor. So at the cervical level, there's three things that go on as a mom is laboring. So dilation is the one most people know about, right? We have to take the cervix from being something that's closed and tight and holding the baby in to something that's soft and open and letting the baby out. In terms of how large the cervix gets, we go from 0 to 10 centimeters. And why 10 centimeters? Because that is the average diameter of a baby's head. And the baby's head is the biggest part of the baby. So once that head comes through, then the rest of the body just follows. So the other things that are going on as well you may not know about, and that the first one is effacement. So effacement is the remodeling of the cervix that's taking it from being kind of this firm, rigid, long structure to something that's basically just completely melted away and, sort of like a spool of thread unwinding, right? So as that all those fibers are strong and holding that baby up and making that cervix a solid structure, it's this very firm thing that we can feel and measure. As the labor process happens, then it just loosens and gives to the point that you can't even measure it, you can't even see it, it's just an opening. So we describe that as going from 0% effaced, meaning your cervix is, theoretically as long as it can be, to 100% effaced. So when that cervix is completely melted away and just kind of flush against the baby's head, then we'll say mom is 100% effaced, and we kind of, go, increase that by our exam. The other process that's happening is something called descent. So the baby's entering the pelvis and moving down through the pelvis during the labor process. And we kind of measure that arbitrarily with numbers that, basically in where the baby is in relation to different bony parts of the pelvis. And so when baby's very high, we're at more negative numbers. As baby comes very low and is close to delivery, we move into positive numbers. So we'll dive into these in a little more detail. So effacement, we said, is a process where the cervix gradually melts, and it goes from being nearly 4 inches long during the first and second trimesters to, as we get into the third trimester, it kind of gradually shortens to more like 3 centimeters, 2 centimeters. But when we're measuring that again, we're kind of just giving it this theoretically full length cervix would be a 0% cervix. The actual structure of the cervix is changing. A lot of people think the cervix is a muscle. It's actually not. It's more collagen, so it's a lot more like your nose than a muscle in your body. So, but that actually changes as the cervix becomes effaced. So we get a lot more hydration into the tissue, and the tensile strength of the cervix decreases, so it softens. And this process actually usually begins before recognized labor starts. That's especially in moms who've had a baby before. So a lot of times, they'll have effacement without really knowing it. And first time moms may be a little more aware of it going on. They may have more symptomatic early labor, and we'll talk about that. So here you can kind of see some pictures of it. So these pictures, you can see the cervix is nice and long. It has structure. You can see that kind of sitting in front of the baby's head. As we move down, and you guys have these slides if you can't really see these well because the room is bright, but you can see here now that length of that cervix has begun to decrease, and you can actually see that the opening, the dilation, is beginning to open up, and these bags of membranes are kind of pushing through there. And when we examine a mom, we'll describe that as bulging membranes, that bag of water is kind of being protruding through the cervix. We can feel that's kind of like a little water balloon in there kind of pushing through. And then this picture shows a nearly fully effaced cervix. So you can see that cervical length is pretty much just flush against that bag of water, and that cervix is nicely opened there. And then when we talk about dilation, again, we're giving that number. I point out this picture over here because, a lot of people are like, well, how do you even know how can you tell? Do you get in there with calipers and measure? And it's a lot more subjective than that. So this little board that you can see here, this is actually what they give, new nurses, midwives, and doctors to help them learn to do cervical exams. So they'll hand that to us, and we kind of sit there with our eyes closed and stretch our fingers in these little holes and try to, conceptualize like, oh, if my fingers are open this far, then she's 3 centimeters. If they're open this far, she's 5 centimeters. And you can imagine that not everyone's sort of this are exactly the same number. And the reason I point that out is just because people do get very fixated on the dilation when they're in labor, and like, I'm not making change. It's not happening, or it's not open enough. But you can have definitely 5 different people examine the same woman and get 5 different exams, both in terms of the effacement and in terms of the opening. And so, just know that it's the whole process of the labor, not just the number. And for example, we're not examining a rigid structure at this point, right? Like, this whole thing is stretchy and loose. So, if I check you when you're having a contraction, for example, the cervix is going to be more open than when everything's just kind of calm and relaxed. If I measure the amount that I can stretch the cervix open to, that's going to be a bigger number than if I just say where the cervix is resting. So in labor, I tend to be a pretty generous examiner, because to me, I want to know how far I can stretch that cervix, because that's what's happening when a contraction is happening. So that's really, to me, the true dilation. Whereas, like, a lot of times nurses, they tend to be a little more cautious, I think, because of like hospital culture of not wanting to call the doctor in too soon if the woman's not really far enough along, because there's a lot of doctors that don't come in till like the baby's falling out. And so they don't want to like over exaggerate how far the mom is. But so, long story short, it's these are tools that we use to kind of show us how the labor is progressing, but they're not super exact. And what's more important is what's happening with your labor process. And there's definitely phases that you go through with your labor process. So if you feel like things are moving forward, they probably are. So don't worry about it too much. Um, a patient, like we said, they're considered fully dilated once that cervix reaches 10 centimeters. So once that cervix is open enough to allow the baby's head to come through. If you have a smaller baby, so, if a mom's laboring early, for example, her fully dilated or her complete may be actually a little smaller than 10 centimeters. If a mom is maybe late and maybe her baby's a little bit bigger, then her 10 centimeters may actually be a little bit more than 10 centimeters, right? Her fully dilated, it may be a smidge more. So, that's kind of an interesting thing. And also, cervical dilation may start before you've had any recognized labor. So with second time moms, this is especially the case. I can have a second time mom walking around at 5-6 centimeters. Recently, I had one walking around at almost 8 centimeters. That made me a little nervous. But with first time moms, usually it's going to be the opposite. opposite. Usually first-time moms are not going to dilate until they start having some contractions, like some recognized contraction activity. So, a lot of people in the latter weeks of pregnancy, they'll be like, oh, will you check me? What's going on? And, they might have a little dilation or they might have none, but it's not really a predictive factor in terms of when they're going to labor. I can have a mom, be not dilated, not effaced, not doing anything, and go into labor the next day. And I can have a mom that's, walking around at 3 to 4 centimeters for weeks. So sort of that value of doing kind of these late in pregnancy cervical exams, we know it's just really not there. So we don't, that was kind of an old fashioned thing of checking everyone in the weeks leading up to labor. We don't really do that anymore unless a mom is feeling symptomatic and having a lot of contractions, and we kind of want to see what things are starting out. So, any questions about that? No? So this is just a little picture in case you don't have a great visual of what centimeters are, if your metric system isn't great, but you could just kind of see that also that cervical effacement and dilation kind of tend to go together as well. So you can't get to a certain point of dilation without some effacement happening, and vice versa. You can't fully efface most of the time until you're getting a little more open. So they definitely do tend to go together, but occasionally we will have a patient who fully effaces even before they dilate. So it's not a given, but in general, kind of they tend to go together. So, as the labor's starting, as contractions are happening, you're gradually seeing the effacement increase, and you're gradually seeing the dilation increase. Okay. So, last process, descent. So, descent is where, the bones of the pelvis start to relax and open and allow this baby to move lower and lower. So, I'm going to show you this with our handy dandy pelvis. So, this is a pelvis. We all have one. And if you see at the top of this pelvis here, this is what we call the pelvic inlet, that bridge, that circle. And you can actually feel this on yourself because this bone right here is the pubic symphysis. And that is the bone you feel at the base of your belly. It's where we kind of measure you from when you come into the office, that kind of firm thing at the base of your abdomen. It's probably a little sore as we move into the third trimester because that baby starts to enter that little circle and do something that we call engage. When this head kind of sticks into this circle, the baby is said to be engaged. And when that baby first enters that circle, that's where we would say that baby is at -3 station. Some people will kind of characterize them, if they're higher up than that, as, -4, -5. I don't. To me, if the baby's not engaged, then I just say that baby's floating because there's nothing that's sort of sticking the baby in the pelvis. That baby can move any which way. And usually the baby will be floating through the second and even early third trimester. So that means the baby can really get into any different position at that point. Once that kid engages with the head into the circle, it's really hard for the baby to get that head up and out of that deeper pelvis. So, yeah. So you may feel it in the third trimester by this bone becoming tender, and you may feel it with a little more just pressure or just even hip discomfort, because you can imagine just that baby starts putting pressure on these hips. This is where the hips would be here. So yeah, you may have some of those sensations or just an increased feeling of heaviness in the lower pelvis. That's all signs that the baby has started to engage. So. And then I'll kind of show you, we've got our little baby here. So if you kind of look, the baby's encased in both the uterus and the bag of water. So this is the bag of water here. So as this baby's kind of coming down, the cervix is opening up, that bag of water breaks, and the baby kind of moves its way through. So you can sort of see that in visual form. And then this is the placenta. Baby comes out, and we detach the cord, which already happened, but we'll ignore that. But if you see how the baby moves in, so the baby comes into that first little circle, and then it just gradually moves its way down. When it reaches these bones right here, which are called the spinous processes, the baby is said to be at zero station. And I always kind of point these bones out because when the baby reaches this place, you can see everything kind of becomes really narrow here, right? That your the pelvic bone, the tailbone rather, is kind of curved up at that point. And at this point, there's two other structures in this pelvis. There's still the bladder right here, and there's still the rectum right here. So as that baby especially gets to those lower, more positive numbers, you begin to feel a lot of pressure on those adjacent structures, and that's very normal. I also point out this because when we talk about like the birth canal and use that terminology, it seems like this must be like this like long journey this kid has to go through, right? Like, oh my God, gotta get this kid through the birth canal. In reality, these bones right here, you can actually feel on yourself. If you just take a finger, insert it in the side of your vagina, you'll feel that little outpouching of that bone. And these bones, they're only about that far up. So when the baby actually reaches zero station, that place right there, if we open the labia, we could actually see the baby's head. And that's the furthest we would ever have you push from. So if mom had a lot of desire to push and sensation to push, that would be the highest up. So, at most you're pushing the baby down this far. So, just a little changing our thought process about this. And you can see this picture just shows, the different stations. By the time we get to that +3 station, the baby's head is actually starting to crown, and you can fully see the head at that point without any manipulation of the labia. It's right there and stretching and on the perineum. How the baby enters the pelvis is called the baby's presentations. That means is the baby coming into the pelvis head down, feet down, or trying to go sideways. So cephalic or vertex with that head in the pelvis is obviously what we want. We typically are going to see that by about 32 weeks. So usually 32, 34 weeks, we'll do an ultrasound to make sure that that baby's in that good position. Some babies, roughly 4% of babies, will get themselves into a breech position, and that means the bottom or the feet are coming out first. And then a much rarer percentage of babies, much smaller rather, it will get into this sideways position. A sideways position or transverse position is undeliverable vaginally, and you can see why, right? But certainly the preferred method for delivery is baby and head down. Breech deliveries are significantly higher risk, so that's why most of babies that are breech in today's day and age are delivered by C-section. Orientation is how the baby is facing, how it's kind of facing on its axis. So when we talk about orientation, we're usually talking about a head down baby, and what we're saying is which way is this baby facing? So is it occiput, back of the head, anterior, meaning up, closest to the front of mom? Is it occiput posterior, the back of the head resting against mom's sunny side up, or is the baby occiput transverse, meaning facing one of the hips? So the ideal position for delivery is that baby is facing mom's back, so what we call occiput anterior. And the reason for that is because this is where baby has kind of the greatest range of flexion. It's also where baby's head can kind of mold and elongate so that a smaller diameter of that head is coming through. When baby is occiput posterior, we don't have nearly the same range of flexion. And also the face can't mold. So really this kind of wide diameter of the baby's head has to make its way through the pelvis. And that's a little challenging. If you've ever tried to crawl under a fence, most of us aren't going to crawl under that fence like this, right? We're going to turn around and go like this to get under the fence. And that's what we want that baby to do, is kind of flex that head, and the fence that it's climbing underneath is this pubic bone. So we want to see that baby kind of moving through the pelvis and stretching up. About 25% of babies will enter labor sunny side up in this occiput posterior position, but only about 7% of them will deliver that way. So yes, if we can ideally get that kid facing mom's back before labor starts, that's ideal. It definitely makes for an earlier labor process, but we do see increasing numbers of occiput posterior babies. And why we think that is because what's maybe changed in our society in the last 100 years? How do moms spend a good chunk of their time? Sitting, right? We're sitting, lounging. And what's the heaviest part of this kid? Right? The back of the head. So this kid's just going to kind of lounge in the pelvis with mom back to back as mom spends a lot of time sitting. So one of the things that you can do in, the latter weeks of your pregnancy is just get up more, walk more, and sort of change the forces of gravity on this kid. So getting on hands and knees, doing, yoga, cow cat positions, or child's pose, things that help flip that baby over. So, and they'll talk about that a little bit more when you come in for the hands-on class as well. Okay. Let's see if there's any other things. So this is just showing again, those orientation pictures of head down, breech, and transverse lie. And then these are again showing those orientations of the baby, depending on how it's facing for mom. Any questions about that? Yeah.
So say that I were to go into labor sunny side up, is there a specific position that you would automatically put me in to try and get?
Yeah, so I generally will do a lot of like hands and knees positioning if we're noticing the baby is sunny side up. And if it goes all the way through delivery, that's often going to be the most successful position to push in. So I'll even have moms with epidurals get on to hands and knees to help try and deliver a sunny side up baby. The other thing is once we're fully dilated, we can kind of reach up and manually rotate the baby's head as well. So sometimes we do that during labor. And then if you guys have you guys seen those peanut balls yet? So the peanut balls and getting kind of different side laying positions, what we call side laying pelvic releases, can also help rotate the baby. So we try to just open up the pelvis in different directions. And a lot of times that'll just help that baby rotate. So that's a good question. Other questions? Yeah, we're good? All right. So, what does each mom experience as all this stuff is going on? Well, first I'll say that no two labors are the same, right? Each labor is kind of its own journey. No two women experience labor in the same way. So, definitely you'll have one woman who's like, oh my God, this was the most horrendous process ever. And some women are sort of like, it's kind of like menstrual cramps, not really a big deal. So you definitely hear it go the full gamut. And believe it or not, 1% of women really report little to no pain during childbirth. They're just kind of like, oh, the belly's getting tight. I'm feeling a little pressure. And then you're looking at them like, are you in labor? Are you actually in labor? And, we call those our unicorn birthers because, it looks so bizarre as you're taking care of them. But that's 1% of women who will experience labor that way. So there's a lot, there's no rules, but we'll kind of go through what generally people describe it and what people generally experience. So the first obvious thing is most women will experience recognizable contractions. What's a contraction? So it's where the uterus becomes firm and the muscles of the uterus contract. So it's going to generally feel like a tightening and cramping sensation that often starts in the back and kind of wraps its way around the front and sort of has some downward momentum with it. It's going to build in intensity both during the contraction, so it kind of has this wave-like pattern, which is why I have the picture of the wave. So it's going to kind of peak and then come down, and the intensity as we go through the labor process is also going to build. So when you start off having contractions, they'll typically be very mild, something you can still carry on a conversation through, be laughing, like, oh, I had one, whereas as we get into more active labor, usually a mother is going to have to stop, she's going to have to really work and breathe through the contraction, and not be able to really carry on a conversation through that contraction. So if I have a mom calling me on the phone saying like, oh, I think I'm in labor, really kind of key sign to me of whether or not she's truly in active labor versus more early labor is, does she have to put that phone down when she has a contraction? I try to keep her on the phone with me a little bit so I can hear her have a contraction. And if it's sort of like, oh yeah, I just had one while I was talking to you, but we've been carrying on a conversation that entire time, probably early labor. But if she's really having to put down the phone, work through that contraction, or if her partner's calling me instead, then that's often a really good sign that that the contractions are strong and strong enough to begin actively dilating the cervix. So women will have contractions throughout their pregnancy, especially in the third trimester. We'll start to notice these contractions, these mild, infrequent, irregular contractions. A lot of people refer to those as Braxton Hicks contractions, but I kind of loathe that word. You may have heard me rant about it in the office already, because to me, a contraction is a contraction is a contraction, and there's not two different kinds of contractions, right? A Braxton Hicks contraction is a contraction, but in order to begin to have the cervix dilate, we need contractions that are strong enough and frequent enough to begin to open that cervix. So that's what we're looking for in labor.
You kind of just answered it, but I need some clarification. Does your water break before contractions then?
Rarely. So most of the time, contractions are going to be the first sign that you're in labor. Only about 7% of women will have that kind of movie experience of, oh, my water broke. Even though that's what's been, shown to us our entire life, right? That's always how water breaks in any TV show or movie. But yeah, it's only 7%. And actually, water breaking without the mom being in labor is considered somewhat of a dysfunctional labor pattern. So most of the time, water's not going to break till we're really in active labor, 6-7 centimeters. So as far as length, contractions are typically going to last between 30 seconds and a minute. Later labor, they may last as long as 2 minutes. Early labor, they can just be a few seconds long. So we're going to see, again, that progressive quality to the contractions, that they're both going to become stronger, they're going to become closer together as the labor moves, and they're going to become that kind of more stable length duration. But it would be considered abnormal for them to go more than 2 minutes. Okay. And in between contractions, you're generally going to feel totally normal. So, if you're having kind of some abdominal discomfort, a lot of times people will be like, well, I'm not sure. Are these contractions? It's like, well, does it have a start and a stop? Are you getting breaks between the discomfort? If you're sort of like having this kind of 30-second to a minute, stomach ache, and then it's easing up and going away for 5 minutes, and then it comes back and you get this stomach ache for a minute, and then you get another break, yeah, that's probably contractions. So and some women experience that not in the front. Some women just feel that in the back, so they'll have this coming and going, painful backache, and that's what their contractions are feeling like. Okay. So in active labor, kind of what differentiates early labor versus active labor is that in early labor, contractions are mild and irregular. You can typically carry a conversation through them. In active labor, contractions are going to be strong. They're going to be progressive in both their intensity and their frequency. And the other key thing is they're going to be persistent. So in early labor, a lot of times if you just change your position or you get in the tub or take a shower, the contractions will just go away. So that's, again, kind of that irregular quality. Whereas in active labor, you can do anything. You can shift your position, you can lay down, get up, move, doesn't matter, they're still going to come. So, another kind of hallmark to me of active labor versus early labor is if you can sleep through it in your bed comfortably, it's probably just early labor. So, a lot of people will feel afraid to go to bed because inevitably all this kind of action typically starts at night. This is always when it goes down. And there's a hormonal reason for that, because melatonin, increasing amounts of melatonin actually promote oxytocin production. So that's why women tend to start their labor process at night. But if a lot of times people will be afraid, like, oh, like, I don't know if, what if I fall asleep and I'm still having contractions and then I don't know I'm in active labor. You will know that I have yet to have a woman, fall asleep and wake up pushing a baby out. It just doesn't happen. So you're totally fine to go to sleep. And, if you're not able to sleep, that's a sign to me that, again, these are more active labor contractions versus early labor contractions. So this kind of slide just shows the contraction pattern through the labor process. So you can see in early labor, what we sometimes call latent labor, the contractions are just kind of all over the place. And, we didn't give this, the true 24 to 48 hour experience that it often is on this graph, but this can be going on for days leading up to labor. Some first-time moms especially will have something called prodromal labor, where these kind of irregular contractions that aren't actively dilating the cervix are enough that they're feeling them and enough that they're uncomfortable and maybe even enough that they can't sleep through them. But they kind of do this, oh, I have a run of, really close contractions for an hour, and then I go 3 hours and don't have a contraction. And, oh, I was up all last night, I finally fell asleep, and I woke up and there's nothing going on. And then we go into the next night and do that whole game again. So that's a really common thing that we'll see with first-time moms.
So when we go into early labor, do we just obviously let you know and then just text you like when we have another
So
one?
generally you're going to be reaching out to your doula during that time and not necessarily paging me, because this, again, it can be a 1 to 2 day experience. So you kind of reach out and talk to the doulas and see what they think, and they'll give you advice. But typically we're going to be having you sort of monitoring your contractions at home, and when the contractions get consistently every 5 minutes, that's when we would typically have you reach out to me, and that's sort of the first time we think about kind of bringing you in. But most of the time you would have been doing some laboring at home before that. For at least, most patients, it's at least 5 to 10 hours of laboring at home before they're going to come into the hospital or birth center. So, but what we say is when the contractions have been every 5 minutes for at least an hour, that's where we would typically have you call. So, because again, just sometimes you might get to every 3 to 5 minutes and then they stop. So, we want to see that consistency, and, and then we'll know it's more likely to be the real thing and avoid the false alarms. As we move into active labor, you can see just the consistency of the contractions. We're not getting these big breaks. We're not getting these big spaces. And again, that interval between the contractions is just getting tighter and tighter. So, it'd be really rare that you go from nothing to suddenly contracting every 3 minutes. Most moms are going to be like, oh, I was having a contraction every 20 minutes. Then I started noticing them every, 10 to 12 minutes. Now they've been, every 7 to 9 minutes. Now they're 5 to 7 minutes. And you're just gradually getting closer and closer to that tight interval. Now, during early latent labor, we are still having some cervical change, but it's just the speed of cervical change at that point. In early latent labor, it may take you 12 hours to go a half a centimeter, and that'd be totally normal. Whereas in active labor, we're going to be dilating at least a half a centimeter an hour. So you can kind of see the difference. So we would tend to define active labor as when you're hitting about 5 to 6 centimeters dilated. So other very common symptom that we talked about is lower back discomfort. Most people are going to describe it as kind of a back strain or spasm, and it's caused by that baby putting pressure against the spine and the sacrum as it moves through the lower pelvis, so it's a really common symptom. And then pelvic pressure is probably the third most common symptom. So just, as that baby is kind of, again, compressing these adjacent structures, we're getting a lot more urinary frequency. We're getting feeling a lot of just like this frequent sensation of needing to have a bowel movement, because as that baby compresses the rectum, that's the signal it sends to your brain of like, oh, I need to have a bowel movement. So the kind of frequent trips to the bathroom. And actually, we can even start to see frequent bowel movements because the same hormones that are stimulating the uterus are also stimulating the bowel. So a lot of women in kind of the hours leading up to active labor, they'll really just kind of empty the bowels and maybe even have some diarrhea. And that would be very, very normal at this point. And again, this pressure intensifies as that baby gets lower and lower in the pelvis. So a lot of people will ask me, oh, how bad are my contractions going to get? Once we're in active labor, the strength of the contractions stays pretty constant. So it's not that the contractions suddenly become, oh my God, screaming, climbing up the walls, uncomfortable, but they become paired with pelvic pressure. And we've kind of been conditioned to feel pelvic pressure and especially rectal pressure as pain or discomfort because, again, what does that often signal in our normal day-to-day life? That we might have an accident, right? So run to the bathroom because, this is going to happen. So we have to kind of retrain our brain that in labor, pressure is progress. Pressure is a good thing. We like pressure. And you'll see, your doula, me, everyone, they'll ask you, like, are you feeling pressure yet? Are you feeling pressure? Do you have rectal pressure? Because it's such like just a classic symptom that things are moving forward, that baby's descending, and everything's working the way that it's supposed to work. Okay. Um, Next symptom that we often see is increased vaginal discharge. So it may be clear or kind of yellow tinged, and many women will report passing like a discrete mucus plug during their early labor process or even as the labor is kind of progressing. And that's because when the cervix is closed, there's this kind of thick cervical mucus that's contained within the cervix, and as things start softening and opening, that thicker mucus will come out. So this is kind of part in the graphic of some pictures of what it looks like, but you can see it's normal for it to have a little like blood tinging in it because, again, what's happening during that time is often that cervix is thinning out. And as that cervix thins out, you do see a little mucousy bloody discharge with that, or what we call bloody show, and it's completely normal. You also might just see like a little pink tinging. It may look kind of like a nice little ball of snot. So, it can look all different kinds of ways. But what wouldn't be normal would be for it to have frank, bright red blood in it, and like you to keep passing just bright red, soaking the panty liner type of bleeding. That would be more than normal. But if it's just sort of, bloody mucousy discharge when you wipe, when you go to the bathroom, completely normal. Other thing that wouldn't be normal would be for it to be soaking your clothes. So if you were noticing a lot of clear liquid discharge that just kind of kept coming out, dripping down the legs, soaking the underwear, or if you felt it coming out in a gush, then that would be much more symptomatic of the water having broken. So, water doesn't always break as sort of a soak the floor event. A lot of times it's just sort of like a trickle, a constant trickle. So if you were feeling that and it wasn't really mucousy, it was really liquidy, then we would be more thinking that's what amniotic fluid as opposed to just normal increased vaginal discharge with the labor. Okay. Any questions about that? Okay. So membrane release, we'll jump right into that. So, as we said, it can be a slow trickle, but some patients do experience it as a complete gush of fluid, or as they shift position, they feel fluid gush out. Some patients even experience an audible pop when the water breaks. They'll kind of hear this pop. I had that. It was great fun. And the fluid that comes out should be clear when it's coming out, or a little bit yellowish or pink tinged. It should not be bloody or look like wine. If it's looking like wine, that wouldn't be normal, like red wine. And it should not look like this kind of neon green or darker yellow color, especially if it has kind of particles in it. That would be concerning for meconium. Meconium is when the baby has a bowel movement inside before it's born, and then all of that little lovely baby poop mixes in with the amniotic fluid and comes out. Passing of meconium can be totally normal in labor, but it does increase the risk that the baby's having some distress or that something else is going on. So if that was going on, we would definitely want to know about it, and we would want to bring in to be monitored sooner. Yeah.
Would meconium be a sign of like a red flag to go to the hospital?
Yes. So if we had meconium, then we wouldn't labor at home. So, for first-time parents, usually if water just breaks and we're not having signs of active labor, then it's okay to stay home and just continue monitoring. Most women are going to go into active labor shortly after their water breaks. So most women will labor within the first 4 to 6 hours, and 80% of women will have labored by 24 hours. So, usually we'll observe you at home for at least a period of time if you're one of those that has water break first or water break very, very early in labor. But if we saw meconium or signs of bleeding with the water breaking, then yeah, we would bring you right in for that. Okay. Um, and then once the water is broken, then that boundary between sort of the sterile world of the uterus and the unsterile world of the vagina is sort of breached at that point. So we do definitely keep track of how long mom has had ruptured membranes, and we do ideally want the baby to be born within 24 hours, or at least labor to have started within 24 hours of that water being broken, because as longer times go on, we see increasing rates of infection. We also wouldn't want anything in the vagina after the water's broken. So no intercourse at that point to try to get labor going. We certainly wouldn't use tampons or anything like that with a mom with broken membranes. But we can still use a labor tub. That's a common misperception, that once your water breaks, you can't use a labor tub. There's no evidence for that. We've actually placed women in bathtubs with dyed blue water and put tampons inside, not pregnant, and seen whether or not those tampons will turn blue, and they don't. So we know that water doesn't go into the vagina when we're in the bathtub, which I think most women kind of intuitively know, but yet somehow we all go crazy when women are pregnant and think that, that water is just going to go right up there and cause an infection. No evidence to that. Okay, so you are fine to still take a bath. Other symptoms that we see are more what we call systemic symptoms of labor. So most women will experience some nausea and vomiting during labor. It's a very common symptom. It tends to be a later symptom in labor, part of what we call transition. And when we use that word transition, what we're talking about is transitioning from the end of active labor to what we call the second stage, where the cervix is fully dilated and mom's getting ready to push. And that's typically happening around 8 to 9 centimeters, that we're getting kind of this transition time that's very, very recognizable as you watch laboring women. And one of the strongest signs is this nausea and vomiting, just sort of the body just starts kind of emptying out. But some moms start to have a return of some nausea and vomiting even in the third trimester, just as that baby's growing and putting a little more pressure on the stomach and the structures in the upper abdomen. Just, they can't eat as much food, there's not as much room, and they kind of get that kind of sort of queasy feeling even in the third trimester. Other symptoms, we talked about frequent bowel movements, so both because of the pressure of the baby on that lower rectum and just all those hormones stimulating the bowel. Shaking is a very, very consistent symptom where just suddenly the mom will start getting shakes and sort of having these flashes from being really hot to really cold, lots of temperature fluctuation, and that's just because of these hormones that are just raging at this point point in the labor that cause sort of this neurologic response. It's very, very normal, but again, it's a sign of advanced labor. So if you were laboring at home and you started to notice more of these things going on, shaking, mom's puking, feeling lots of rectal pressure, you might be further along than you think you are. So that would definitely be a time to reach out. And then the other really common symptom is just fatigue. The process of labor is very demanding on the body. Calorically, you're going to use up as many calories as if you had run a marathon. And interestingly, if you've ever watched marathon runners where they kind of collapse at the finish line, we'll even see that effect in mothers after they deliver, where just they can't move. They're like their whole body just sort of gives out. So while you're working through labor, again, especially first-time moms who this process is generally long, really important to take the time for rest, give your body kind of that little recuperation time in between contractions, and also give yourself proper hydration and nourishment. It's going to be a really important part of your labor and delivery care. Mom needs energy, mom needs to stay hydrated. If we don't do that, we can actually see labor slow down and not progress in a normal way. So it's an important part of kind of care of mom during that process. A lot of people, when they're sort of wanting to go into labor or wanting to get labor to progress, especially in that kind of early labor time, they'll like try to do a lot of physical activities. They'll go, walking around the block, walking upstairs. And even in a lot of the doula blogs and things that you see online, you may see encouragement to do a lot of this physical activity. I tend to be the opposite in terms of my philosophy towards it. I think, as we're moving into that early labor, you're starting to have symptoms, that's the time to rest. Like we need to bring down stress hormones. We need to just let this process happen. And we sort of need to fill the bank, so to speak, of energy and sleep for going into this labor process. So I really just encourage people in early labor, just chill, hang out, rest, let your body do what it needs to do rather than trying to force it to go into labor by, running up and down the block. So that's my theory anyway. In terms of labor timeline, you can see, we go through these different stages of the labor, and basically everything in early labor, active labor, and transition is going to be considered stage 1 labor. If you're reading any older books or watching videos, you might hear people still use these terms to describe that labor. But stage 1 labor, obviously getting that cervix from a closed cervix to a completely open cervix, that's where you're going to spend the bulk of your time in labor. That's what, and it obviously has its different little phases of where things look very different during those times, depending upon where we are in that labor process. Stage 2 is the pushing or delivery stage. And stage 3 labor is placental delivery, which most people don't think anything about because it usually happens without too much notice or effort from you. But in the literature, it is kind of given its own terminology for that time in the process. The early latent labor, in terms of how it correlates to dilation, as we said, it's going to typically be when mom is at 0 to 5 centimeters, so sort of those earlier stages, and usually where the cervix is not very effaced. So contractions will typically be irregular and spaced out. They're most of the time going to be mild. We may still be having some of that mucus and birth show happening during this time, but it's, again, very rare for the water to release at that time. Only, I think I wrote here 8%, but 7 to 8%, depending on the study you look at. And then the other key can be, again, those frequent bowel movements, which we can still see in the early labor process. Active labor is going to be regular contractions, typically spaced 3 to 5 minutes apart. So it'd be really rare that you could get to more advanced dilation without having contractions that close together. Again, there's some crazy people that just are really, really dilated, really advanced, but, especially first-time mom is not going to get to 6 centimeters without contractions being at least every 5 minutes. And then those contractions, again, typically are taking breathing, they're taking focus. We're not just chit-chatting through them. And very commonly, water is going to break during this time. So, if you've been laboring at home, you've been with sort of maybe what was seeming like an early labor pattern, but then your water breaks, then that could be a sign that we're probably moving into active labor. So if I've had a mom contracting for several hours, then her water breaks, that I'm going to typically bring her in, even if we're not quite hitting 5 centimeters, because again, contractions every 5 minutes, because again, there is the occasional mom who doesn't really feel all of her contractions, but they may still be going on if we put her on a monitor. So, and then transition or advanced active labor, that's going to be when contractions are typically going to be spaced 1 to 3 minutes apart. You're going to have all of those systemic symptoms that we talked about. So see how that changes and progresses. In terms of how much time you spend in each of these stages, early labor is going to make up at least 60% of your labor. And interestingly, that's first or second time mom, so whether you've had a baby or not. So average timing is going to be 12 to 18 hours in early labor, but we definitely can have patients who spend several days in early labor. So it just kind of depends on your body and how your body's moving through this process. Active labor is going to range between 3 to 8 hours for most patients, where people who've had babies before are going to tend to be on that shorter end of the process, whereas moms who have not had a baby before, it's going to tend to take longer. So first-time moms are usually about a 0.5 centimeter an hour. A mom who's moving nicely through labor, maybe 1 centimeter an hour, but it takes some time. And then transition is usually only about an hour, but sometimes, especially if we have maybe one of those little sunny side up babies, it might be a little longer. We might see it stretch more into 3 hours of transition, but most commonly it's a pretty quick process once we get to transition. Stage 2 labor is, again, that process where now the baby's through the cervix, the head is through the cervix, we're fully dilated, but we still need to move that baby through that kind of lower part of the bony pelvis. The ease and length of this stage really is affected by so many different things. So one, baby size and position. So smaller babies facing the right way are a lot easier to push out than bigger babies facing the wrong way. But other factors that can influence it are mother's pelvic shape. So there's definitely different recognizable shapes in the female pelvis, and there's certain types of shapes that are a little easier to deliver versus others. Another thing that impacts it is just mom's energy level, how she's positioned, and whether or not she has an epidural. So, if you're kind of blessed with a really quick early labor, you progress through active labor really nicely, and we've only been at this, 6-7 hours, you got a good night's sleep the night before, you're probably going to just like push your baby out like a champ. If you've been laboring for 3 days and you haven't slept and you're exhausted, then it's obviously going to be a little more challenging and, take a little more time for you to deliver. Epidurals tend to, especially for first-time moms, tend to increase the pushing stage by anywhere from 1 to 3 hours. So most moms without epidurals will deliver their baby typically in under an hour. If mom's had a baby before, often it's less than 30 minutes. If especially first-time mom, has an epidural, then it's very common for it to take 2 to 4 hours. Beyond 3 would be considered a little excessive, but still most of those moms will be able to deliver their baby if we just give them a little more time. But it's a process. So, a lot of people, pardon me, a lot of people think like when mom's fully dilated, it's like, oh, the baby's just going to be born in 2 seconds. But this is one where, again, we've been, lied to our whole lives by all of the movies. It's usually just kind of a slow, calm process to get to delivery, and it typically takes, a significant chunk of time and some significant work. The most moms at this point are going to feel an urge to push. In sort of hypnobirthing, they're very anti using the word push, and we will kind of teach you different ways that you can work in terms of, breathing the baby out and moving the baby through your body. But I will say that's kind of the one area that, I sort of differ a little bit because, just in all the patients I deliver, it's really, really rare that a woman doesn't specifically say the words to me, I feel like I need to push. Like that's typically what a woman's body will tell her. And when we say I need to push, what it typically is going to feel like is I need to have a bowel movement. And you're actually using those same muscles to deliver the baby that you would use to have a bowel movement. So, you're going to typically contract the abdominal muscles and bear down into the bottom, and that's how the baby is born. Um, I'll wait on this little video, but commonly patients will have a little anxiety about that because we typically don't poop in front of friends. And there is certainly that anxiety of pooping on the delivery table because people talk about this in hushed tones. And it does occasionally happen. It's considered very, very normal because if you sort of look back at those pictures where that rectum is coming right underneath the baby, everything's getting really narrow there. If there is something still remaining in the rectum, there is no place else for it to go but out. And so that baby will compress the rectum and sort of squeeze it out like a toothpaste, tube. And you have zero control over it. If mom tries to prevent that from happening, because she's, that's what it's feeling like, then she just won't deliver her baby. So there really has to come to the point where you just go, screw it, we're just getting this baby out, we're pushing this baby out, and not really worry about it. And this is kind of one of those things where, I always tease labor and delivery in the delivery room, birthing center, it's Vegas. Like what happens in that room never leaves that room. We don't talk about it. And we'll totally lie to you if you ask. We'll sweep it away, we remove it, and it's really, really not a big deal. And in fact, everyone who works in labor and delivery, when we see poop, we're like, yes, because poop is progress. Pressure is progress, but poop is progress too, because it means that baby's getting low, the mom is doing what she needs to do to deliver the baby. So we see it as a great thing. So, poop on. Um, I'm going to show a little video that just kind of puts all these things. Can you guys see that? I know it's bright here in the morning. We need drapes in this room. But this just kind of shows the baby moving through that lower pelvis and kind of the way the baby turns and rotates. Sort of put it all together. You'll see even if the baby's kind of entering this lower pelvis in a different position, most babies are going to just sort of rotate into the correct position because it's the easiest way for them to get underneath that bone. And then once the head delivers, very next contraction, the first shoulder is going to deliver, typically the top shoulder, and then the bottom shoulder, and then the rest of the baby just kind of flies out. and that's true. So that's not fake news on that one. Let me close this. Stop. Technology, work for me. So the head is really what you're working for. The rest of the baby really does just come out just very quickly right after the head's delivered. So it'll take a really long time to get that head out. And you kind of saw that baby sort of rocking back and forth. They actually do that. Like you'll push the baby forward and it'll look, oh, we're really, really close. And then it kind of rocks back a little bit. And then the next contraction, we move it forward a little bit more. Then it rocks back a little bit. So it's kind of this little like seesaw action working to just kind of ease that baby under the bone. And that slow process of delivery is a great thing because that helps all those tissues stretch just kind of naturally. It eases the baby through and reduces tearing. So we like a nice, slow, controlled delivery. And, we're trying to be very, very gentle with the tissues of the bottom to help reduce any tearing at that time. So sometimes we'll use nice warm compresses on the bottom. We'll sort of support the bottom as that head's coming through and do everything we can to minimize that. Okay. Um, Placenta delivery, like I said, most people don't even know the placenta is being delivered. It's like, oh, what was that? Oh, that was the placenta. And then we'll inevitably get the ew. But it doesn't have bones, so it's much easier to get out. And at that point, the cervix is nice and wide open, so it generally just eases out, usually within just a few minutes of the baby being born. Some signs that the placenta is ready to be delivered is that we can see the umbilical cord start to lengthen. We also may start to see a little increase in vaginal bleeding. For partners in the room, that may look like a lot of vaginal bleeding and look a little scary, but it's a totally normal process after that placenta is delivered. We help massage the uterus to help it contract down after the placenta comes out, because if you can kind of imagine this uterus that had this baby and placenta, it was really big and stretched and open. And at the time the baby's born, up to 40% of your blood supply is going to the baby at that point. So there's nice, big, dilated blood vessels that are feeding this uterus. And what we need to happen is we need that uterus to really quickly shrink down, become nice and hard and firm, so that those blood vessels aren't open and bleeding through the vagina. So we'll do that. We may also give a little medication to help with that. So we'll sometimes give a synthetic form of oxytocin called Pitocin right after the placenta is delivered to help that uterus contract and minimize bleeding. And then if mom did have any tearing, that's typically the time that we'll go in and repair any of those tears. And we'll talk more about that when we kind of do the medical part of it, of how that process looks. And so, again, time differences in first and second labors. Everyone here is a first time mom, so you're kind of falling in this category, but we'll also talk about second time mom. So, for first time moms, again, in early labor, we'll often see some effacement before we get dilation. So, that sort of mom's only 1 centimeter but completely effaced, that's typically going to be a first time mom. We usually have early labor with first time moms be symptomatic, so meaning that they're feeling those contractions, they're aware of them. They don't usually just sort of dilate without knowing it's going on. Most of the time, you're going to know it's going on. You're going to have a recognized early labor process. And sometimes it's prodromal, meaning that you're having a lot of symptomatic contractions. They may even be at that 3 to 5 minutes where we would think you're in active labor, but we're still 1 centimeter, and it takes us a really long time to get to the next centimeter and a really long time to get to the next centimeter. That's what we call that prodromal labor. And it's annoying and it's awful, but it's very, very normal for first time moms. And it doesn't necessarily mean there's a problem. It's just how your body's going through it. And then during active labor, most of the time, we're going to see first time moms dilate at about a 0.5 centimeter an hour. But I definitely have patients who don't follow that rule and who look a lot more like a second time mom, even in their first deliveries. So, again, these are just generalizations, but sometimes we'll have a mom progress really quickly. So if you're having those signs of being in more active labor, don't ignore them and just be like, oh, this is going to take 12 hours, because not everybody does. Some people do move very, very quickly through their labors. As far as second stage or the pushing stage, up to 3 hours is considered completely normal. And in terms of tearing, a little more common for first time moms to have some perineal tearing, no matter how kind of slowly we control everything and, use our warm compresses and use our oils. It's very normal. But the good news is these tend to heal very quickly, and they're not as uncomfortable as you might imagine, especially if it's just a more, normal, mild tear, because there's a lot of good blood flow to that area. And just even the pressure of the baby against the perineum tends to numb the area. So you don't necessarily feel the tears happen for most patients. Second time moms, usually they're going to dilate before they efface, and most often their early labor is pretty asymptomatic. They may not really recognize that it's going on. They're kind of the moms where it's like, yeah, I was running around picking the kids up from school, and an hour later I was in strong, active labor and, delivered the kid 3 hours later. They're the moms who've had babies before. Those are kind of your story of like, oh, all of a sudden my water broke and I was delivering a baby on my kitchen floor or in the car, those kind of more dramatic, faster labors. So all the work you'll do in this labor, this first labor, it's making it so much easier for the second labor. Our biggest concern for second time moms is getting them to their place of delivery on time, and not having a baby sneak out too soon. And so their active labor is they're going to typically dilate at about a centimeter or half an hour or even more. It's not uncommon for me to have a mom go from 6 to being ready to push in just a couple contractions. They can very quickly progress. And then their second stage, their delivery phase is going to, whether they have an epidural or not, it's going to typically be less than an hour and most commonly just a couple pushes. So when to call. So for everyone, if you're having more than 4 contractions per hour, when you're pre 36 weeks, and that's been going on for at least 2 hours, I would want to hear from you if we're having those early labor contractions. If your water's broken, I always want to check in with you. So even if you're not having any signs of labor, you should call me if you think your water may be broken. If you're having abnormal vaginal bleeding, so, something more than just that little bit of, show when you wipe, if it's something that's really kind of, soaking the pad, coming out in any sort of gush, we would definitely want to hear from you. And then baby not moving well. So once we get to 28 weeks, we should be feeling regular, consistent movement of the baby. If you feel like that baby's not moving well, if you can't get your kick counts, then that would be a reason to call. And during labor, sometimes it can be, especially early labor, it can sometimes be difficult to recognize whether the baby's moving. So a lot of times we'll have moms do more kick counts during that early labor, where they really put their hands on their belly and really try and count the movements of the baby. And you should be able to feel the baby move at least 10 times in the hour. So the contrary to what you might hear on, internet, baby shouldn't stop moving during labor. So you should still be able to feel that baby move. Okay. And then for first time moms, when you're having regular contractions that are strong enough that you're having to breathe through them, lasting 30 seconds to a minute with an interval typically of 3 to 5 minutes. If you live far away, then we might you'd stretch that out a little bit and have you start thinking about coming in when they're more at that 5 to 7 minutes. But if you're close by, 3 to 5 minutes is going to be fine to get you here, get you settled, and and still have plenty of active labor to go. If water is broken, most of the time, first time mom, we're going to be comfortable with letting you stay at home as long as everything looks good for at least a period of time. But for a second time mom, if water breaks, because that can so quickly escalate labor, even if you weren't having a lot of symptoms, we're typically going to bring a second time mom in. And second time moms, again, we're going to usually bring them in a little sooner in their process just because of how quickly those labors can progress. So typically when the interval is between 5 to 7 minutes from the start of one contraction to the start of the other. And that's how we measure the time. So from start one to the start to the next. And there are little contraction tracking apps that you can download on your phone that are helpful. Again, if it's not really getting down to those closer ranges, don't bother with it. You'll know when it's time. Prioritize sleep over tracking the contractions. But as you're getting closer, as things are becoming more active, then, that's a helpful tool to keep track of where things are at, where you can just press a little button like contraction started, contraction end, and it'll tell you what your interval is and how long that's been going on. So that's helpful. And that's it for labor. Questions? Okay. Yeah. All right. Let's take a little break and get a drink, stretch, and then we'll try to come back in roughly 10 minutes so we don't have the day stretch out too long, and then we will get into all of the lovely medical management of labor. Okay.